Good afternoon, everyone. My name is Michelangelo Mancuso. I'm the co-chair of the Mitochondrial Working Group of the EURO-NMD, and it is my pleasure to restart a nice mitochondrial tradition we have built in the past 3 years. As you may be aware, September is the month when we celebrate the Mitochondrial Awareness Week. And for the third year, together with the ERN board, we decided to have a cycle of webinars focusing on different aspects of mitochondrial medicine. All the previous webinars were very successful, and they are available on the YouTube channel of our EURO-NMD, but also they are part of an online course that you can freely enjoy on the Moodle platform of our ERN. I guess Elizabeth will copy the link in the chat, so you can log in this Moodle platform, and where you can find a lot of material for education, and there is a mitochondrial course that you can take and also obtain a certificate. So hopefully also this third cycle of webinars that start today will be successful, and we hope we can provide knowledge to all the participants on different aspects of mitochondrial medicine. So today is our first day, and it is my pleasure to introduce the speaker, Caterina Garone. Caterina, of course, is an Italian female, a very good friend of the mitochondrial community in Italy, in Europe, is an active member of the EURO-NMD Mitochondrial Working Group. She's an associate professor of medical genetics at the University of Bologna, and also a child neurologist consultant at the Neurological Scientific Hospital of Bologna. Caterina was working in very important, prestigious labs during her career, and in her early stage. She was at Columbia University in New York with Professor Iran and Professor Di Mauro from 2010 to 2014, if I remember correctly. And she was basically one of the person who developed all the pathomechanism, and leading actually now we are very close to the therapy of nucleoside supplementation in thymidine kinase 2 deficiency in humans. And most of the work in this field was developed by Caterina a long time ago. Fortunately, Caterina, you're not so young anymore.
No.
And after Columbia, she moved to Cambridge in UK, working for the Cambridge Mitochondrial Biology Unit, and where she was keep working on mitochondrial disease and exploring disease mechanism related to mitochondrial DNA replication defect syndromes. She is now back in Italy since 2019, thanks to the Rita Levi Montalcini Rientro Cervelli Award. She set up in Bologna a very nice lab, a very interesting group of young researchers exploring different aspects of mitochondrial medicine. So Caterina will cover an important topic, as you see, the acute onset infantile mitochondrial disorders. She will have a more or less 40 minutes lecture. Please put your questions in the chat, and at the end of Caterina's lecture, we will have time to answer to your question. So Caterina, the floor is yours now. Enjoy, and very happy that you can be the first speaker of this new cycle of webinars. Thank you, Caterina.
Thanks, Michelangelo, for this very nice introduction, and also thanks for the EURO-NMD for giving us the opportunity to start this third series of webinar on mitochondrial disorder. Today we really focus on infantile age, on acute onset, and the idea of this webinar is because infant patient that start with mitochondrial disease require a multidisciplinary team and require high skill and knowledge about mitochondrial disease to suspect the disorder and then diagnosis. Just really, Michelangelo basically covered all my career, and that was very nice of him. I'm based in Bologna, as associate professor at University Bologna, and I work as a child neurologist at the neuropsychiatric unit. We do have a lab that is talking with our clinic, and the main goal of our lab is to try to understand the disease mechanism and develop novel therapy. So definition of mitochondrial disorder back in 2001 covered the main aspect of this disease that are genetically determined clinical syndrome and independently by the genetic defect, the final pathways are energy, metabolism, dysfunction in the mitochondria. We have three main characteristics. They are genetically determined in terms of Mendelian inheritance, if we have a defect in the nuclear DNA, or maternal inherited, if the mutation is the mitochondrial DNA, and clinically they might be multisystemic or tissue-specific. The clinical and genetic aspect is associated with a biochemical defect that can be isolated, or we might have a multiple oxphos defect in affected tissue. This definition that was used back in 2001 now is summarized with a clinical syndrome that can have any symptom, any tissue of any age. Although the central nervous system and the muscle are the main affected tissue because there are high energy demanding tissue, and are also the tissue that we can easily study thanks to neuroimaging, metabolic analysis with spectroscopy in the brain, or histochemical and biochemical analysis in the muscle biopsy. Unfortunately, any organ and tissue might show sign of mitochondrial dysfunction. And in terms of inheritance, we want also add that there can be any inheritance because the mitochondrial DNA that is present in multiple copies inside of mitochondria is able to encode just few protein for the mitochondrial oxphos subunit, but it requires a subset of nuclear DNA gene that we count around 1,200 that encode mitochondrial protein that work in all of these pathways. So we can have both Mendelian and maternal inheritance depending on the nuclear gene defect that is, or the mitochondrial DNA gene defect that is affected. Starting from today's topics, we will talk about acute onset, and the idea of this webinar is try to share with you my experience presenting some cases that we had chance to follow in the past 5 years here in Bologna. When we have an acute onset in the infantile age, we might have two main different scenarios. The first scenario is a patient that arrived to our attention with a general condition due to metabolic acidosis. The second scenario is a metabolic acidosis that is associated with one main organ or tissue that is going to failure, like heart failure, liver failure, kidney failure, or a CNS acute onset with the status epilepticus or stroke-like episode. We might have also the unfortunate case of neonatal death in which a neurologist, a clinical geneticist, a metabolist might be involved further for the diagnosis, for mainly a preventive therapy or prenatal diagnosis than in a second affected child. When we talk about metabolic acidosis, we talk about a patient in which both neurological, respiratory, cardiovascular, or gastrointestinal system might be affected, might show sign of disease. The patient arrived to our attention with a reduction or a different degree of impairment of the consciousness. So they might have confusion, they might be already in lethargia or even in coma. And also in terms of neurological condition, most of the patients have hypotonia. Vital sign and particularly the respiratory and cardiovascular show tachypnea, tachycardia, and hypotension. Patient might have acousmal respiratory dysfunction with deep and rapid breath, and they might show sign of poor perfusion. In some cases, they also arrive to our attention with nausea, vomiting, or a brief history of poor feeding. How we recognize, how we differentiate a metabolic acidosis that is due to mitochondrial dysfunction. When patient is metabolic acidosis, first of all, the pH is below 7.2. The ketone level might be normal or increased, but the most important parameter is the plasma lactate that is very high in the plasma and in some patients also in the CSF. When we look to other parameters like the urinary organic acid or glycemia, their level might be slightly abnormal or normal. And the most important parameter is the ammonium that in our patient is normal or slightly increased. So we are not having a metabolic acidosis with a hyperammonemia, but with an increase of lactate and a variable degrees of impairment or other parameter. Why we have an increase of lactate when we have a defect in the mitochondrial respiratory chain activity, the pyruvate cannot enter in the citric acid cycle, and so it accumulates right at the beginning of the pathway and can be converted either in lactate or alanine. So both these two parameters might be high in the plasma of our patient. For the same reason, since we have a block in the mitochondrial respiratory chain activity, we might have an increased excretion of some Krebs cycle intermediate, and this is nicely identified by analyzing the urine organic acid. Since in the mitochondria, we also have the urea cycle, also the level of citrulline might be abnormal with a reduction of citrulline, or we might have a defect in the level of acid glutamic and the glutamate that might be slightly increased in our patient. In some cases, the urine organic acid can guide us for a specific mitochondrial disorder. If we have an ethyl malonic aciduria, we might think to AT1 defect. And similarly, if we have an increase of the free methyl glutaconate, we might think about BIF syndrome or Magdel syndrome. So the first patient that I like to present is a patient in which the mother had in the first trimester a miscarriage, and then during the third trimester she had poor maternal weight gain. The child was born at term with normal delivery, vaginal delivery, but since the first hour of life, he had severe hypotonia, and the colleague noticed that he had hypoglycemia and tachypnea. By analyzing the metabolic status by umbilical cord blood gas we identified that patient had metabolic acidosis, and specifically the pH was 6.9, the level of CO2 was 9, and the BE was 12.4. So the patient was transferred immediately in the neonatal intensive unit care, and there was a first attempt to treat the metabolic acidosis with an infusion, a low level of glucose and sodium bicarbonate. The neonatal team performed a cranial ultrasound, and they noticed that there was a white matter changes but no focal lesion. The treatment normalized the level of glucose, but the patient was poor responsive for the treatment with sodium bicarbonate. So the metabolic acidosis was still there after the first attempt to treatment. So we admitted him to a third level of neonatal intensive unit care. In this case, we noticed that there was, together with the metabolic acidosis, a slight increase of the ammonium, 246. The lactate was very high, 386, and there was an increase of lactate also in the CSF. We perform an additional investigation in terms of cranial ultrasound, and we noticed that there was a defect in both the gray and white matter in the basal ganglia, while the EEG didn't show epileptic abnormality, but there was a severe suppression of the background activity. In terms of heart involvement, there was no defect except for a systemic hypotension that was due to the metabolic acidosis. We tried to treat the patient together with the sodium bicarbonate with dialysis, but it was ineffective, and the patient was dead at 5 days of life. During these 5 days of life and caring of patient, we had chance to run metabolic exam, and as you can see here, there was an increase of lactic acid also at the urinary organic acid level. And also, although here I didn't highlight them in green, you can see that there was several metabolites of the Krebs cycle that were increased in the urine of the patient. None of them was important to diagnose a specific metabolic disease, but altogether this slightly increase are important because they are guiding us to a mitochondrial dysfunction. The alanine level together with the lactate was increased in the plasma and the CSF, so confirming that there was a block in the OXPHOS activity and the pyruvate was accumulated in the biological sample in the increase in both plasma and CSF as alanine and lactate. When you have an infant, first day of life, that has metabolic acidosis and several conditions, you need to fast act for a muscle biopsy and, if possible, also skin biopsy to derive fibroblast. So in general, we try to perform a muscle biopsy as soon as possible because it allows us to confirm the diagnosis, to go ahead with diagnosis, even if we lose the patient during this process. And this is very important for the family for a future pregnancy. In this patient, the muscle biopsy showed at histopathological level just mild myopathic changes, but when we ran a biochemical analysis of the muscle homogenate for the respiratory chain activity, we identify a defect in complex 3. In the ultrastructural analysis of muscle biopsy, there was also some degenerative feature of the mitochondria that was visible in the muscle cells. We did a genetic consultation with the family. The parents were not consanguineous. and there was no history for a mitochondrial disorder or other metabolic disease in the family. We ran a first test with the ARA-CGH that was normal in patient a normal karyotype. But when we did whole exome sequencing, we found two different variants in the BCS1L gene that encode a protein that is important for the assembly of the complex free. So the two variants were in trans were inherited by the two parents and were pathogenic, so they were predicted to be damaged. And since we had also a complex free deficiency, this was in agreement, and we confirmed the diagnosis of BC1L related disorder. So BC1L causes a spectrum of disease that goes from very mild phenotype, the Jornal syndrome that is characterized by pili torti and sensory neural hearing loss, to very severe disorder like gracile syndrome or Lee syndrome. The gracile syndrome specifically stands for growth retardation, aminoaciduria, cholestasis, iron overload, lactic acidosis, and early death. So it's difficult to give to our patient a very detailed clinical diagnosis, because in the 5 days of life that he had chance to live, we noticed some sign of gracile syndrome, but also CNS involvement. But definitely the association of the clinical phenotype plus the complex free biochemical defect and the identification of the two pathogenic variants allow us to confirm the diagnosis and to further proceed with the other pregnancy in the family for a prenatal investigation. The second case is instead from a consanguineous Pakistani family. He had one older brother and one older sister that were both healthy. So he was third child, was born at 41 plus 4 weeks, so with a normal delivery and an eventual pregnancy. However, at 12 hours of life, he presents again with tachypnea, hypotonia, hyporesponsiveness, and the accustomal type breathing pattern. The laboratory finding confirm a severe metabolic acidosis with a pH 6.3 and an increase of ammonium 206. He also had an elevated CK level 1000 units per liter and aketotic hypoglycemia. The patient was immediately treated, transferred to neonatal intensive unit care, and treated with a CPAP for the respiratory dysfunction and sodium benzoate and arginine for detoxification. And since there was no immediate response, we started also with hemodialysis. There was a rapid improvement in terms of the metabolic acidosis, and the ammonium became normal soon after the treatment. However, the patient required transfusion because he had a very low level of platelet and hemoglobin. At the cranial ultrasound, again, we had an increase of the echogenicity at the basal ganglia, and specifically we had an increase then at the brain MRI of the T2 image, weighted image at the thalami, with a lactate peak identified in this lesion by the brain MRI spectroscopy. So post-dialysis, we had the normal level of the lactate, normal level of the amino acid, and also a normal level of the pH of the patient. But he started to have few days after, we noticed few days after that he had a cardiac involvement. And specifically in a month for life, following 3 mild steps of evolution, he had clearly cardiomyopathy with hypertrophy of the left ventriculi. There was a non-compacted myocardium, and there was an increase of LF filling pressure. So during his life, and specifically in the first year of life, he had several metabolic crises that required intervention with both treatment with bicarbonate, but also supportive intervention for feeding and for the respiratory function. All of these metabolic crises were triggered by infection. And then after 6 months, he stabilized, but he had a very complex clinical phenotype with cardiomyopathy, psychomotor delay, axial hypotonia, and he was able to do very few movements with his arm and legs. The muscle biopsy was performed in the first month of life after stabilizing the patient, and it was very helpful to guide the diagnosis for a mitochondrial disease, because the patient have negative staining for the cytochrome oxidase and the muscle biopsy, so he had COX negative fiber. When we ran the biochemical activity in the muscle homogenate, we found a multiple oxidase defect with the complex 1 and complex 4 deficiency, and the whole exon sequence confirmed the presence of 2 different variants in the nuclear gene MTU1 that were in trans and both known to be pathogenic. So in this case, we had an onset with acute metabolic acidosis, and after a month, the patient was clearly having a phenotype characterized by central nervous system and heart involvement with cardiomyopathy. The muscle biopsy show multiple oxidase defects, so we do not have an isolated complex deficiency, but more than one complex was involved. And in fact, MTU1 is one of the genes that is involved in the mitochondrial DNA translation. The clinical phenotype was perfectly in agreement with other patients that have been already published with this disorder, in which we might have, in addition to CNS and cardiomyopathy, also optic atrophy. And so we confirm the diagnosis in the patient. So when to give you a few take-home message, when we consider when we have a patient with metabolic acidosis, if the ammonium level is not so high to consider other metabolic defect, it's important to analyze anyway the plasma and the urine amino acids, the urine organic acid, and the acyl carnitine together with the plasma and CSF lactase, because they can guide us for the diagnosis. The muscle biopsy must be performed immediately because it allows us to, first of all, go ahead with diagnosis and confirm mitochondrial myopathy. But it's also very important because immediately after the muscle biopsy, we can start some supportive treatment. The skin biopsy we do routinely together with the muscle biopsy for deriving fibroblast. And even if we do not have in our, if you do not have the opportunity to run immediately a trio exon, it's important to have immediately the trio DNA sample from the 2 parents and the child, because the disease might be very progressive in the first few weeks. Once the patient is stabilized, it's important to perform a deep phenotyping, including as a minimum level a brain MRI and heart and liver ultrasound. And in terms of treatment, we do not consider as an option anymore the mitococktail because there are no evidence for a mitococktail that to function in our patient. But what we do in general is to start a coenzyme Q10 supplementation and consider other supplement based on the clinical sign and symptom patient and based on the diagnosis. So in the second scenario that we are considering, we might have one specific organ or tissue that is involved in our patient. And some patient might have an acute onset with heart failure. So the cardiomyopathy is estimated to occur in 20–40% of children with mitochondrial disease, and this might be the first and only sign of the disease or may represent a complication. In terms of clinical symptoms, they might be completely asymptomatic, but we also have patients that have heart failure and sudden cardiac death. The most common phenotype is a hypertrophic cardiomyopathy, but in my experience, and this is what in general often happens for this patient, they might have a first stage of hypertrophic cardiomyopathy, and then they will develop a dilatation when they are close to heart failure. So there might be some patients that also present as a dilated or restrictive or left ventricular non-compactation cardiomyopathy. There are some specific also defects that are associated with a defined cardiomyopathy. The cardiomyopathy might develop into a systolic dysfunction and are frequent. Cause of the cardiac manifestation are frequent together with a metabolic decompensation and a frequent cause of death in our patient. So in terms of specific phenotype, we also know that there are the Kern-Cell syndrome that more than a cardiomyopathy is associated with a atrioventricular block. There are isocytosis cardiomyopathy that is linked to a specific mutation, the mitochondrial DNA, and restricted cardiomyopathy might be the only sign for a mutation 1555A2G in the mitochondrial RNA gene. There are conditions in which we know that there is a clinical phenotype associated with a specific organic aciduria, and those syndromes are due to a mitochondrial dysfunction, like the BAF syndrome, which we have an increase of the 3-methyl glutagonic acid, or the TMM70 disorder. There is a specific defect in the complex 1 assembly, which is due to a mutation in a gene called ACAD9 that is important because it stabilizes the complex 1, and as a cofactor, the protein works when it has as a vitamin B2 riboflavin as a cofactor. So in a specific condition due to a defect of ACAD9 and complex 1 assembly, patient might have a neonatal fatal outcome because of cardiomegaly. So when we have a patient with a neonatal onset of heart involvement, especially if we have a cardiomegaly, it might be useful to start immediately with a riboflavin treatment, even if we are not sure that is a complex 1 defect in the CD9, because in the very rare case of a CD9 defect, this might improve the survival of the patient. A third case that I like to present you today is a patient with a familiar cardiomyopathy. In the family history, in fact, there was a first sister that died at 8 months of life because of dilated cardiomyopathy. And it was reported that this was in the context of a mitochondrial dysfunction because in the sister we did not have the genetic diagnosis, but we knew that there was a complex 1 and complex 5 deficiency. The patient that I had chance to follow was born from normal delivery and an eventual pregnancy. He had a normal neonatal adaptation, but the clinical onset was at 2 months of life. He had hypotonia, respiratory distress, and he started to have poor feeding tolerance. So he arrived to our attention mainly because of heart failure, and the heart failure was due to hypertrophic cardiomyopathy. Those are the ultrasound that nicely my cardiac team shared. And as you can see, there was an intraventricular septum of 50 millimeter, and the ejection fraction of patient was already 25% when he arrived to our attention. Except for the poor feeding status and hypotonia, he did not have any other sign of the disease. We did a muscle biopsy that was not so informative except for finding an increase at the red oil staining and fiber atrophy. We tried to stabilize during the hospital admission the heart failure with supportive therapy, including also mechanical ventilation. But 1 month later, the patient had again an acute heart failure episode and cardiac arrest, and he died at 3 months of age. At that time, the ejection fraction of patient was 15%. Thanks to the DNA sample that we collected onset of the patient, we were able to run a whole exome sequencing, and in this case, we identified 2 compound heterozygous variant in the LAS2 gene, so LAC2 gene. This gene is associated with the combined oxidative phosphorylation deficiency, so it was in agreement with the biochemical defect that we found in the muscle biopsy, and also is one of the genes that has as a main clinical phenotype a cardiovascular involvement with hypertrophic cardiomyopathy. So LAC2 related disease are characterized by growth failure starting from prenatal age, lactic acidosis, psychomotor retardation, and hypotonia. Patient can also experience hearing loss and GI dysmotility, but as you can see in our presentation, when you have a main organ and the first organ that is severely affected, the patient might not show all the signs of the disease, and they might die even before to show the full clinical phenotype. So when you have patient that has heart failure, you want to always consider involve a mitochondrial expert at the very beginning of the clinical investigation and clinical study of patient, and consider, of course, an early onset cardiomyopathy. A cardiomyopathy can be the first sign of mitochondrial disorder, but in some cases, may be also the only sign of a mitochondrial disease. This is very important because if you associated the clinical phenotype with genetic diagnosis and with the non-natural history of the disease, you might consider also an organ transplant in some patients that have a mitochondrial disease. The suggestion in these cases is always to start with coenzyme Q10 supplementation after the muscle biopsies, and might be useful in this patient to supplement them with the riboflavin in case you have a very rare defect in the CD19, or in case you have a complex 1 deficiency. An acute onset with a main CNS involvement can be one of the pediatric neurology emergency situation. In this case, the main clinical condition with which patient can arrive to your attention are stroke-like episode or a status epilepticus or refractory seizure, coma, or other acute encephalopathy. So stroke-like episode is, of course, very rare. It's common in Miller syndrome that has a juvenile onset, so it's extremely rare in infantile age, but there are few reports that are associated with the ND6 variant in the mitochondrial DNA. Whereas the status epilepticus is one of the most common pediatric neurology emergency that can happen in acute onset of mitochondrial disease. And there are some clinical syndrome that most frequently are associated with status epilepticus, and they can have a neonatal age, like the FARS2 defect, the Alpert syndrome, and Lee syndrome. As I mentioned before, patient may arrive to your attention in coma, especially if he has metabolic acidosis. And there are other disorders that in their complexity and their spectrum of clinical phenotype may also have an acute encephalopathy as a onset. So just to go a little bit into the detail, the Lee syndrome is defined by the presence of bilateral changes with T2 hyperintense in the basal ganglia. In the classical form, patients start to have clinical signs and symptoms before age of 2. There are many neurological phenotype with hypotonia, epilepsy, neurodevelopmental delay. There are also other forms with late onset or a Lee-like form in which, other than the mainly neurological involvement, we have other organ and tissue that might be affected. In the scenario of Lee syndrome, a patient in general, you notice first a developmental delay, but in some cases, patient may start with seizure and may reach to your attention because of refractory seizure. The Alpert syndrome is one of the clinical phenotypes that are associated with a Bologna defect. The epilepsy may present as epilepsia partialis continua or status epilepticus, and there is also an involvement of liver that is very severe because it might rapidly progress to liver failure. In the Polk syndrome, especially in Alpert syndrome, it's important to avoid the use of valproic acid or sodium divalproate because it can trigger the liver dysfunction, and so can increase the progression, the rapidity of the progression of the disorder to liver failure. Another very early onset of infantile epileptic encephalopathy that also may often begin with the status epilepticus as FARS2 defect. The seizures are mainly focal with the associated facial or eye twitching and myoclonical jerk. Patients have elevated level of lactic acid in plasma and LCR. and the brain MRI in these cases might show no specific abnormality like diffuse cortical, subcortical cerebellar atrophy and thinning of the corpus callosum. This disorder is very progressive and patient might have an early death in infancy. As an example of mitochondrial encephalopathy that might have an acute onset, I like to bring to your attention also defect in ATP6 and 8. Defect in ATP6 has been previously associated to NARP syndrome, or Mill syndrome, so maternal infantile lead syndrome, but we noticed that in our patient, 92% in our cohort, 92% of patients have an acute CNS involvement, and as you can see here, they may have an onset with lethargy in 20% of cases. In the clinical course, many patients have metabolic crisis, especially in the infantile onset. And interestingly, in these cases, you have, in addition to an increase of plasma alanine, also a reduction of plasma citrulline. We do not have for the status epilepticus a clear indication for patients below 28 days of life, but the working group guided by Michelangelo Mancuso recently published also some indication for a status epilepticus in a very early onset patient that I would recommend you to read and follow if you have a patient that has such acute onset. I'll try to go a little bit faster now because I can see that we are already at the 40 minutes. And in terms of gastrointestinal symptoms, definitely liver failure is very important because patient might start in the first month of life with a slight increase of transaminase, rapidly progressive to liver failure. And in some cases, there are some metabolites can guide us for the specific diagnosis, like for DGK, there is always an increase of plasma tyrosine. This was a case that arrived to our attention in the first 2 hours of life with the metabolic acidosis and hypoglycemia. We ran a metabolic screening and deep phenotype of patient. As you can see, since the 10 days of life, he had a liver involvement that was rapidly progressive to liver failure. The diagnosis was a DGK deficiency in the patient, and this is one of disorders that in the mitochondrial community we started the most because in the neonatal infantile age, there is a mainly involvement of liver disorder, while the disease behaves as a spectrum. So when we move from the neonatal infantile age, we have CNS and muscle as a more involved tissue. As a disease that is rapidly progressive, and since the liver failure start, patient can die in a few weeks. So it's very important to diagnose. And some patients might benefit of a transplant because might be isolated to liver. Okay, I'm going very fast on this, and I just want to give you just 2 brief hints in terms of metabological complication. Another acute and very severe onset is for patients with Pierce syndrome, in which we have anemia with thrombocytopenia and pancytopenia. In the majority of cases, this is due to a large addition of the mitochondrial DNA. Patients have a fatal disorder in infancy with sideroblastic anemia and exocrine pancreas dysfunction. In other patients, there might be a condition in which they become transfusion dependent, like in the Melassa syndrome, in which we have mitochondrial lactic acidosis and sideroblastic anemia again. And the last organ that might have an acute onset in patient with a failure is the kidney, in which the clinical phenotype might be a Fanconi syndrome, and this is mainly due to a rearrangement of mitochondrial DNA, or a distal tubular acidosis, and again, the main phenotype is a rearrangement, a large deletion of the mitochondrial DNA, or involvement of the glomerulus with the focal sclerosis. And in this case, the main diagnosis is a coenzyme Q10 deficiency that is important to recognize immediately because with the high level supplementation, at least peripheral organ may have a good response. So the take-off message for this final group of tissue-specific disorder is that they might progress to failure in very few weeks, and the mitochondrial dysfunction is in the affected tissue. So if you have a liver dysfunction, you might not have a severe phenotype in the muscle, but you can recognize a biochemical defect or the depletion in the DNA in the liver, and the genetic diagnosis is extremely important for considering supplementation, but also in some isolated cases where you have only one organ involved in the clinical course, you can consider the organ transplant. And I thank you for the attention. And available for the question now.
Okay, thank you, Caterina. It was very interesting overview of what can happen to the newborn when they suffer from mitochondrial disease. And yeah, I mean, I'm an adult neurologist, and after your lecture, I got scared because, you know, for us at least, despite the status epilepticus, the stroke-like episode, we don't really need to run as you have to run with these children to try to do something for them. So it's not easy. So my my question for you, I mean, of course, everybody can ask something and use the chat. So I will read and Caterina can reply. But while we wait, what's the real prevalence, Caterina, in the emergency setting of a mitochondrial disease? Because, you know, you have clearly shown that we may have acute heart failure, kidney failure, liver failure, metabolic acidosis. So about how much really mitochondrial disease impact in the newborn with an acute manifestation?
Well, as we said, although singularly they are very rare, since we have several different conditions, more than 1,000 different genes that can affect the mitochondrial function, it's actually not so rare, especially if you have an acute onset with metabolic acidosis. It's hard to give a specific percentage, but in my clinical activity, at least once a week, I have a patient with acute onset that I suspect that there is a mitochondrial disorder, and we need to run with the muscle biopsies and taking a biological sample from trios.
Okay, so it's an important message. So it's not so impossible to face these kind of problems if you work in.
No, that's why you need to work with a multidisciplinary team. And although as a background, I'm a neurogeneticist, both neurologist and geneticist as well, I work with the gastro team for the liver failure, with the cardio team for the heart failure, and we always consider a mitochondrial disorder when you have so progressive clinical phenotype in patient.
Okay, and you mentioned that it is important in several aspects, the echography, also the ultrasound of the brain. It is, of course, important, the EEG in these kids with acute manifestation. How important, you didn't mention really nerve conduction studies and the EMG in these children?
We do not run a EMG and nerve conduction study, at least it's very rare to use it in the emergency setting because the neuropathy is something that happens later in life in the spectrum of the disease. So unless we have, we have to do a differential diagnosis with the other neuromuscular disorder, if we are, if our suspect is for a mitochondrial dysfunction, this is very rare to use in an emergency setting.
Okay, thank you.
We do more in terms of neurophysiological investigation. We do more the potential for visual and also auditive activity, because those are very important for us, because patients might have sensory neural hearing loss or might have optic atrophy. So this is something that we do to complement our investigation.
Okay, so Caterina, I don't see questions in the chat, but people are still with us. So I think it was very much appreciated, your webinar. I think it was very clear, very useful, and it will be published on YouTube channel, so it can be reviewed in the future. So okay, thank you, and looking forward for the second webinar next week. And it is already announced on the website. So for the ones who didn't register yet, you can go on the website, register to the next webinar. So thank you, Caterina. Thank you, Elizabeth, for the assistance, and thank you for all the participants.
Thank you very much.
Thank you. Bye.
Bye.
See you next week.
Bye. Ciao. Thank you.
Ciao.